Thank you for joining us for our educational webinar, Carpal Tunnel Syndrome. Tonight's speaker will be Dr. Gary Millard, Orthopedic Hand Surgeon at OrthoNeuro. Dr. Millard is a board-certified, fellowship-trained orthopedic surgeon specializing in hand and upper extremity care and surgery. He attended the University of New England College of Osteopathic Medicine and completed his residency from Oklahoma State University at the Hillcrest Health Center in Oklahoma City, Oklahoma. Dr. Millard is fellowship trained in hand surgery and trauma. He has served as the consulting team physician for the Columbus Blue Jackets and Ohio University. Dr. Millard will answer questions following his presentation. Please type your questions into the Q&A below at the bottom of your screen. Dr. Millard?
Thank you. Thanks very much. All right, so as mentioned, I am Dr. Gary Millard. I'm a board-certified orthopedic surgeon. I specialize in hand and upper extremity surgery. I've also completed a fellowship in trauma surgery, so I do a lot of upper extremity trauma. What we are going to talk about tonight, however, is not trauma. It's probably one of the most common issues that face hand surgeons during our practice today, and that is carpal tunnel surgery. And it stopped working. Morgan. Sorry, give me 1 second. I'm having a little issue with my moving forward here. All right, sorry. So what we're going to talk about now that I figured that out is basically the definition of carpal tunnel, what it is, who we find, what patients we find with carpal tunnel symptoms, causes it, what causes it, some of the clinical features, the complaints patients arrive with, and some of the diagnostics of it and how we treat it. And I went backwards. I'm sorry about that. And I'm sorry, I keep going backwards here for some reason. There we go. All right, so carpal tunnel syndrome is the most common peripheral neuropathy. And what carpal tunnel is a compression of the median nerve at the wrist. So when we look at the carpal tunnel, it's actually an anatomic structure. It's a very small enclosed space. And what happens through the small area called the carpal tunnel is we have 9 tendons passing through that. That is basically all the tendons that flex our fingers, as well as the median nerve. So it is a very confined space for a number of structures. When the median nerve is compressed at the wrist, it results in numbness or pain in the wrist and going to the fingers. So basically, carpal tunnel affects approximately 3% of all adult Americans. It is 3 times more common in women than men. Highest prevalence rates have been reported in people who perform repetitive wrist motions, often with computer users. That's probably the most common finding. Of those people that present complaining of carpal tunnel type symptoms that we'll go over again in a minute, 30% of them complain of hand numbness and tingling. 10% of people actually fit the clinical criteria for carpal tunnel. And of those, 3.5% actually have abnormal nerve conduction studies. So basically, only 10% of the people that actually complain of numbness in the hand actually have nerve studies that confirm carpal tunnel. When it comes to carpal tunnel, there are a huge number of factors that can be included. I've just included this list so that everyone can see that the huge number of possibilities that cause carpal tunnel. Again, one of the most common questions that I get asked is, what caused my carpal tunnel? Why did it happen to me? Why did it happen in my non-dominant hand as opposed to my dominant hand? And this is just a short, abbreviated list of any possible causes of carpal tunnel. So when it comes to clinical features of carpal tunnel, people will often complain of pain, numbness and tingling in the hands. Most patients complain of their symptoms are worse at night and awaken the patients frequently. They often wake up at night complaining that they have to shake their arm or flick their wrist to try to get their hand feeling back normal again. It feels like there's no blood going to the hand. A lot of times the pain and paresthesias don't just occur in the hand. A lot of patients complain of pain that feels like it goes all the way from their hand up to their elbow, up to their shoulder. Another very common complaint is that patients complain of a loss of dexterity. That means that they have a harder time using their hands, picking stuff up, feeling stuff. They feel like they tend to drop things a lot and they're not even aware of they're dropping it. I'll show you a picture in a minute, but atrophy of your thenar muscles, that's the muscles in the base of your thumb, those can atrophy, and that's usually a sign of severe carpal tunnel. Again, patients often will have bilateral symptoms. Generally, one hand will be worse than the other, and a lot of times it does not coincide with the hand of dominance. This is a picture of the thenar atrophy. If anyone's that's listening, if you look at your thumb, at the base of your thumb, you can see a fairly well developed muscle area there. This small circled area shows you the sign of atrophy in those muscles. That is a sign of severe carpal tunnel. Some physical exam, there are a few things that we look for when we examine people. And I'll show you a little bit about each one. First off, the Phelan's maneuver is basically we flex the patient's wrist all the way down to about as far as they can tolerate, or 90 degrees, and hold it there for about a minute to see if the patient's symptoms are reproduced by this. This is, again, compressing the area in the carpal canal, so putting a little more pressure on the nerve. A Tinel sign is usually the most uncomfortable for the patient. And what we do is right over the carpal canal, we just tap right on the nerve and look to see if they get numbness going in the median nerve distribution that kind of reproduces their symptoms. So when we're looking at diagnostics for carpal tunnel, first thing we listen to is probably the most important thing is the patient's history. We listen to their complaint, see when they're having numbness, see where the numbness is, and how much that bothers them and when it bothers them. A physical examination, as I mentioned before, primarily the Tinels and Phelan's. We also do a compression test where we just put pressure straight over the nerve and wait to see if that reproduces the symptoms. If these findings are positive or patients complain of a recurrence of their symptoms, usually the next thing we do is something called a nerve conduction study, where basically, and I will admit it is not the most fun test to go through in the world, but basically you get little shocks in your fingers and electrodes record how fast the conduction goes across your nerve. And that can actually help you determine, and is what helps determine basically whether the carpal tunnel is mild, moderate, or severe. And it confirms our findings on diagnostic studies. Once carpal tunnel is confirmed, we have a few treatments we look at, and we say, somebody has carpal tunnel, how do we treat these patients? First general measures we look at are some behavior modifications. We try to have patients avoid repetitive wrist and hand motions that may make their symptoms worse. Try to avoid the use of vibratory tools. A lot of people that use drills or anything that vibrates on a consistent basis that can really irritate the nerve. So we try to limit that motion. And then we can try to change the way people work. If they work at a computer, we can try to give them a little pad to rest their wrists in a slightly different position so they're not putting as much pressure on the nerve. So we try to just limit how much stress they're putting on the nerve and the wrist area. There are a number of things. Some things work, some things don't. If you're looking at the screen, the picture on the left with this fancy looking pen, that's probably not something that's going to help you that much. If you look at the picture on the right, that's somebody's mouse pad on there with a small bump for their wrist that just changes the angle of your wrist to make things a little more comfortable to take out the stress on the wrist. When it comes to wrist splints, this is something we try on most patients. It's generally the most effective when it's used within the first 3 months of onset. When it comes to the best regime for this or the best use of the splinting, the first thing I always encourage people is to use the splinting at night. That usually helps them sleep a little better. And again, if they're working on the computer all day, using the splints when they're on the computer does help take some pressure off the wrist itself. These are just a couple examples of some splints. The one on the left is obviously a lot more cumbersome, but that is something that usually works very well for people to sleep in. It's a little harder for people to work in there. And even the ones on the right that are very small, but they can help just by adjusting the angle of your wrist when you're working on a computer. There have been a lot of studies with carpal tunnel about different medications people can take to try to help the carpal tunnel. People have used diuretics to try to decrease some swelling in the area. They've tried non-steroidals. That is something like naproxen, ibuprofen, Advil, vitamin B6, and oral prednisone. What has been found is that these different drug regimes can work for a short period of time, but generally they don't work for a long period of time, particularly the oral steroids. They will work in the short term, but it is not something that's going to help maintain a decrease in the symptoms. So the next thing we look at, if just the splinting doesn't work, is doing an injection. And we do a steroid injection right into the carpal canal. And admittedly, it is not terribly comfortable. But the theory behind doing the injection is we put steroid right into the local area to try to decrease some inflammation around the nerve and the tendons around the nerve. That should help with patient's symptoms. Again, we usually suggest splinting after we do the steroids. If the first injection is successful for an extended period of time, and I'd say more than a week or 2 weeks, then usually we'll look at doing another injection. If the injection does not improve the patient's symptoms for more than a week, or if we do 2 injections and the patient still has symptoms, then we start talking about surgical intervention. So again, the surgery is for patients that have failed to respond to conservative measures or in patients with significant nerve entrapment. And that's something that is, again, confirmed on those nerve conduction studies. One of the things to note is that even in patients that have normal studies, surgery can sometimes be effective. And a lot of times we'll confirm that based on doing a steroid injection. If that resolves the patient's symptoms, we will still look at doing surgery if somebody has negative nerve tests. So the surgery itself, basically what we're looking to do is relieve pressure on the median nerve. And the way we do that is by releasing the transverse carpal ligament. As you can see in the diagram on the left, that transverse carpal ligament is what's putting pressure on the nerve. This diagram that you're looking at right now is one of the old ways that people used to have carpal tunnel surgery done. And patients will come in and talk to me and say, hey, I had a friend that had the surgery done and they had this huge incision. Nowadays, we tend to make a much smaller incision. And again, the primary goal of our surgery is to release the transverse carpal ligament. That is the ligament over the nerve that puts pressure on it. And there are two ways we do this. The diagram on the left you're looking at, that is a more modern, the way we tend to do an open carpal tunnel release now through a much smaller incision, or the diagram on the left is when we do the surgery through an endoscopic approach. Again, previously, patients used to leave after carpal tunnel in a splint like you see on the left or the bottom right. For the most part now, when we do a carpal tunnel surgery on somebody, they leave in a small dressing, as you see on the top right. Going back there. So a lot of times when you approach doing the surgery for carpal tunnel, it is a surgeon's comfort on the way they do the surgery, whether they do it open or whether they do it endoscopically. I, over the recent years, have leaned towards doing the surgery endoscopically. It is just my preference. I feel like it gets patients back to doing their normal activities just a little quicker than doing the open surgery. And the incision heals a little better and quicker on the wrist where I do the surgery than in the palm of the hand. But again, that is a surgeon's preference. And when we look back, we are both, either way, you are completing the same goal, and that is releasing the transverse carpal ligament that puts pressure on the nerve. So just to conclude all of this, so again, carpal tunnel is the most common focal peripheral neuropathy. That means, in simple terms, that it is the most common nerve that's affected by compression in the periphery of your body, either the elbow, wrist, knees, foot, and ankle. The most common complaints are pain and paresthesias in the distribution of the median nerve. So that includes the thumb, index, middle finger, and if people have actually read the textbooks, the one side of their ring finger. And when we look at the physical exam, the Tinel sign, that's tapping on the nerve, and the Phelan's maneuver, which is flexing the wrist all the way down, are the most classic signs of carpal tunnel. Also, the other complaints are hyperalgesia, which is basically losing some of the feeling in the fingers, that you feel like you're starting to lose control and not feeling stuff. Again, one of the common complaints is people struggle doing up their buttons on their shirt or doing up the buttons on their pants because they cannot actually feel them. Late signs include the weak thumb abduction because of the muscle hypertrophy. And those are often more predictive of people's symptoms than an actual nerve conduction study. Thank you. If anyone has any questions.
Alrighty, we have a few, so I'll go just from top to bottom. Our first question is, how long does the steroid injection last typically?
So unfortunately, that again is something we cannot predict very well. It varies patient to patient. And that's a lot of times the first injection is a trial. For some patients, it can last up to a week or less. For a lot of patients, it can last up to a year or more. So unfortunately, it's something we cannot give an exact answer to. It is very individual as to how patients respond to the injection.
And then how many injections can you have?
I would do, generally we try to avoid too many injections. What unfortunately will tend to happen is if a patient has a long period of relief from the first injection, often the later injections do not last quite as long. And if we've done more than 3 injections and the patient's symptoms keep returning, that's usually when we'll talk about entertaining the surgical intervention.
And then will my numbness go away completely after surgery?
And that is a very tough question to answer. And a lot of it depends on the severity of the symptoms and the severity of the carpal tunnel before doing surgery. What I usually explain to patients is that they will have some immediate relief. Usually the patient's immediate response is that they actually finally got to sleep through the night because their hands didn't get numb on them. If patients are numb before we do the surgery and they have severe carpal tunnel, we cannot always guarantee that the feeling is going to come back to normal, but usually they will get improvements for up to about 3 months from surgery. I'm sorry, I have company with the animals checking on what I'm doing.
No problem. Okay, the next question is, how long does it take after surgery for the numbness to go away?
Again, I tell patients that it'll take sometimes up to 3 months for most of the numbness to resolve completely. I would say at least 50% of my patients, when they come in for their follow-up visits 2 weeks after surgery, tell me that their numbness is almost completely or completely resolved.
Will you do surgery on both wrists at the same time?
Generally, I do not do both wrists at the same time. That is just because I like the patient being able to take care of themselves. They do need to take care of some of their daily functions. So I like them to have one hand that is not in a dressing that they're able to use well. I will usually do them about 2 to 3 weeks apart, but my preference is not to do them both at the same time.
And then what does it mean that I have permanent nerve damage? If I have surgery, will my symptoms decrease?
Even if you have permanent nerve damage, yes, your symptoms should decrease. If somebody has permanent nerve damage, that means that usually indicates that they've had severe carpal tunnel for an extended period of time. And generally, the carpal tunnel will get progressively worse. So our goal is to actually take the pressure off the nerve. First thing it does is it stops it getting worse. And the next thing it does is it allows the nerve a chance to recover. If someone's told they have permanent nerve damage, getting 100% function of the nerve back is unlikely, but getting a significant amount of the recovery is possible.
How do you decide which hand to do surgery on first if both are bad?
I usually leave that up to the patient. If I'm going to do a surgery on both hands, I will let the patient decide which hand they want done first.
And then I have numbness in the little finger. Is this carpal tunnel?
Numbness in the little finger is usually not carpal tunnel. That more often will be, if it's in the little finger and the ring finger, it will be something called cubital tunnel syndrome, which is compression of a different nerve. It's compression of the ulnar nerve, and that usually occurs at the elbow.
Are there any more questions? All right. Thank you for participating in tonight's webinar. Our next webinar will be on March 3rd at 7 p.m. Dr. Benjamin Zerlup, orthopedic shoulder surgeon, will be speaking on rotator cuff tears. Look at our social media pages for additional information to come. Thank you and good night.
All right. Thank you.